Hi friends, we have been seeing many of the topics. Now today we will see the obstetric emergency. Here I am just mentioning some of the obstetric emergency, all the obstetric emergency, but going in detail only with the some of the obstetric emergency because other portions I have already covered. If you have any doubt, you can ask me and clarify your doubts. Okay, so it goes. Obstetric emergency. Any disease or condition occurring suddenly with a great potential to endanger the life of the mother or the fetus. That condition we call it as an obstetrical emergency. The conditions include abortion, ectopic pregnancy, antepartum hemorrhage, eclampsia, postpartum hemorrhage, rupture of uterus, inversion of uterus, amniotic fluid embolism, sepsis, obstructed labor, fetal distress, cord prolapse, solid dystocia. These all comes under the obstetric emergency. These all are some or other way which endanger the life of the mother as well as the fetus. So some of these conditions I am not going to deal in detail in all these conditions because many of these conditions I have taken class in detail. So some of the condition we will see. The first one is solid dystocia. I hope this also I have covered, but still I'll go in. It is the inability to deliver the fetal shoulder after the delivery of the head without the aid of specific maneuvers, that is other than the gentle downward traction on the head. The pathophysiology of shoulder dystocia include it results from a discrepancy between the fetal shoulder and the pelvic inlet when the bisacromial diameter is large relative to the biparietal diameter and the pelvic brim is flat rather than the gynecoid. In these two conditions, shoulder dystocia occurs. That means the head is delivered and the shoulder is not able to deliver. The predisposing factors include fetal macrosomia, obesity, diabetes, mid-pelvic instrumental delivery, post-maturity, multiparity, anencephaly, fetal ascites. Fetal hazards or complications include fetal asphyxia, injury to the brachial plexus, fracture femurus, claviculosteomastoid hematoma during delivery, perinatal mortality, and morbidity small. The maternal hazards include increased operative delivery, morbidity. Diagnosis. How we can diagnose that means there is a shoulder dystocia. Definitely recoil of the head back against the perineum. That means when the head is delivered, the head has to come forward, isn't it? But in this case, the head will go back to the perineum. Then inadequate spontaneous restitution. These two conditions we can diagnose it is a shoulder dystocia. Management principle. Some dose that call for extra help, clear the infant's mouth and nose, involve the anesthetist and pediatrician, perform a wide mediolateral episiotomy if not made earlier. Then don't be panicky, don't give traction over the baby's head, do not apply fundal pressure. Then the step 1, the head and neck grafts and taken posteriorly with a suprapubic pressure is applied by an assistant. It will reduce the bisacromial diameter and rotate the anterior shoulder towards the oblique diameter. If that fails, we can go for the McRoberts maneuver, abduct the maternal thigh and sharply flex them onto the abdomen. There will be a rotation of the symphysis pubis upwards and decrease in angle of pelvic inclination. Step 3, Wood's maneuver under general anesthesia, posterior shoulder, rotate anterior by screwing movement. This is done by inserting 2 fingers in the posterior vagina simultaneously. Suprapubic pressure is applied. Extraction of the posterior arm, operator hand introduced into the vagina along with the fetal posterior humerus. The arm is then swept across the chest, thereafter delivered by a gentle traction. If fails, baby is likely to dead by this time. Step 5. Cledotomy. One or both clavicle may be cut with scissors to reduce the shoulder grip. Then the second next obstetric emergency is called prolapse. Cord lies below the presenting part of the fetus. We call it as prolapse. Occult or hidden or not visible, cord placed by the side of the presenting part and not felt by the fingers on internal examination. That means the cord is on the side of the head, between the head and pelvis. When we do a vaginal examination, we may not be able to feel the cord. That is the condition, the occult or hidden. Cord presentation means cord slipped down below the presenting part, felt by intact bag of membrane. When the membranes are not ruptured, the fluid is still there, so we can feel the cord in front of the head. That is the cord presentation. Cord prolapse, cord lying inside vagina or outside the vagina following the rupture of the membrane. Please understand that occult and cord presentation occurs before the rupture of membrane. Cord prolapse means cord comes out after the rupture of membrane. Etiology, how it happens. Anything which interferes with the perfect adaptation of the presenting part. That means head is a well-fitting presenting part. Cephalic presentation, when the head is coming, because head is in a round shape, so it fit perfectly to the pelvis, so nothing can be swept. But if it's an ill-fitting presenting part, face, buttocks, shoulders, in those cases there is a gap found between the presenting part and the pelvis, so the cord can come out. Like malpresentation, contracted pelvis, prematurity, twins, hydramnios, placental factors like placenta previa, iatrogenic like rupture of membrane, manual rotation of the fetus. Diagnosis. Occult prolapse difficult to diagnose. Possibility persistence variable deceleration of the FHS by HCTG. Cord presentation diagnosis made by feeling the pulsation of the cord to the intact membrane. Cord prolapse, cord can be palpated directly by fingers and its pulsation can be felt if the fetus is alive. Temptation to pull the loop for the visualization or unnecessary handling to be avoided to prevent vasospasm. When we touch with our hands, sometimes the vasospasm can be induced, so the fetus will get reduced the blood flow. So temptation to pull down the loop for visualization or unnecessary handling is to be avoided. The first aid management of cord prolapse aims to decrease the pressure on the cord when the patient is prepared for assisted delivery or transferred to a tertiary hospital. Because the membranes are not ruptured, we have only felt the cord while doing a vaginal examination. So if our hospital or our setting is not sufficient to conduct that particular delivery, we have to transfer. For the transfer, we have to prepare aim to decrease the pressure on the cord. So bladder filling has to be done. So when the bladder is filled, we have seen that in the first stage of labor, when the bladder filled, the descent of the presenting part will not take place. So when the full bladder, then lift the presenting part off the cord, place a glove inside the vagina. Then postural treatment, elevate seams position with pillow under the hip. That means the extremity, lower extremity has to be elevated. Replace the cord into the vagina. Then prompt recognition is important. Fetal hypoxia resulting from prolonged cord compression result in CNS damage or death of the fetus. If the cervix fully dilated, forceps or vacuum assisted birth can be performed for a fetus with cephalic presentation. Otherwise, cesarean section is likely to perform. No reassuring FHS, inadequate uterine relaxation, bleeding can occur as a result of prolapsed umbilical cord. Interventions. Call for extra help. Insert the fingers of gloved hand into the vagina to the cervix with one finger on either side of the cord or both fingers on one side. Exert upward pressure against the presenting part to relieve the compression of the cord. Place the woman into an extreme Tendenberg or modified Sims position or Nature's position. The cord is protruding from the vagina, wrapped loosely in a sterile towel saturated with warm sterile saline solution. Administer oxygen to the woman by the mask 80 to 10 liters per minute. Why we are administering oxygen? If the mother gets more oxygen will be transferred to the fetus. Start IV fluids or increase the existing drip. Continue to monitor the fetal heart sound, psychological support to the woman. Next obstetric emergency is obstructed labor. In spite of good uterine contraction, the progressive descent of the fetus presenting part is arrested due to mechanical obstruction, that is the obstructed labor. Causes: the fault in passage. Passage is the pelvis, bony contracted pelvis or CPD. Soft tissue obstruction due to dystocia due to prolapse or previous operative scar. Then fault in the passenger. Transverse lie, bra presentation, congenital malformation of the baby, big baby compound presentation, locked twin. Anatomical changes. Uterus gradually increase in intensity, duration and frequency of contraction. Relaxing phase become less and less. Ultimately, a state of tonic contraction develops. Retraction continues, lower uterine segment elongates and progressively become thin to accommodate the fetus driven from the upper uterine segment. Circular groove encircling the uterus is formed between the active upper uterine segment and lower uterine segment is called as a pathological ring or Bandel's ring. Bladder. Bladder becomes an abdominal organ due to compression of urethra between the presenting part and symphysis pubis. The patient fails to empty the bladder. The bladder wall gets traumatized, which may lead to blood-stained urine. Base of the bladder and urethra, which are nipped in between the presenting part and symphysis pubis, may undergo pressure necrosis. Devitalized tissue become infected and later on may slug off, resulting in development of genitourinary fistula. That means when the presenting part is compressing a long time in the urethra, there will be infection, necrosis will be occur, infection will be occur, necrosis may follow. So the infected area will be slug off and it may end up in a genitourinary fistula. Effects on the mother. Immediate effects include exhaustion due to pain and anxiety, dehydration, metabolic acidosis, genital sepsis, injury to genital tract, postpartum hemorrhage and shock. Death due to rupture of uterus and sepsis with metabolic changes. The remote complications include genitourinary fistula, variable degree of vaginal atresia, secondary amenorrhea following a hysterectomy or due to Sheehan syndrome. Effects on the fetus include asphyxia, acidosis, intracranial hemorrhage, infection. All these lead to increased perinatal loss. Prevention. Obstetrical labor, the present day obstetrics it's very rare, and if any patient come with an obstetrical labor, it is a complete negligence from the healthcare worker, so it should not occur. So the prevention include antenatal detection of factors likely to produce the obstetrical labor, intranatal detection, continuous vigilance, use of partograph, timely intervention to prolong labor. Clinical features of the obstetrical labor include patient is in agony with continuous pain, features of exhaustion, abdominal examination shows upper uterine segment hard and thinner, lower uterine segment distant and tender. Pathological retraction ring obliquely between the umbilicus and symphysis pubis rise upwards in course of time. Fetal parts may not be well defined, FHS usually absent. Internal examination shows vagina is hot and dry, discharge is offensive, cervix fully dilated, membranes absent. The treatment in the principles include to relieve the obstruction, to combat dehydration, ketoacidosis, to control the sepsis. Preliminaries: dehydration, ketoacidosis are corrected, vaginal swab, blood sample, antibiotics has to be given. Obstetric management. Before we go for any obstetric management, rule out rupture of uterus. There is no place for the wait and watch. Vaginal delivery, if the baby is dead, and many of the neglected cases, baby will be dead. Then if the baby is alive, we can go for a cesarean section. Next, obstetric emergencies, rupture of uterus. Dissolution in the continuity of the uterus any time beyond 28 week. That means after 28 week there is a continuity or breakdown in the uterine continuity, we call it as a rupture of uterus. Then you may ask, what is it for before 28? Before 28 weeks, if there is any dissolution in the continuity, we call it as a perforation. Etiology, it can be either spontaneous. It is a complete, involves the upper uterine segment. Spontaneous can occur during pregnancy, previous damage, that there is a weakness of the uterine wall following D&C or manual removal of the placenta. Sometimes there will be no cause, especially in case of multiparity. Weakness of uterine wall result from fibrosis, out of bruising, stretching or tearing of uterine muscles. Congenital malformation of the uterus, and during labor it may be because of obstetrical labor, involves the lower uterine segment. Non-obstetrical in case of grand multipara, usually occur in early in labor, involves the fundus and it may be complete. Second type is scar rupture, uterine scar following operation on a non-pregnant uterus, hardly rupture, and as the wound heals well, because uterus is quite following, uterine scar following hysterectomy behaves like a classic one, and it is the one which gives concern, because if you to go for any surgery before means in a non-pregnant uterus it may heal properly, but hysterectomy it behave like a classic one and which will give a growing concern. During pregnancy, weakening of the scar due to implantation of the placenta over the scar. Sometimes the placenta may implant over the scar, so it may rupture. Then during labor, hysterectomy scar is more vulnerable to rupture during labor. Then third type is iatrogenic or traumatic. During pregnancy, injurious administration of oxytocin, so the uterus may go into a hypertonic contraction and it may end up in a uterine rupture. Use of prostaglandin for induction. Then forcible version under general anesthesia, fall or blow on the abdomen. During labor, internal podalic version, destructive version, manual removal of the placenta. An application of forceps or breech extraction through an incompletely dilated cervix. All this gives way iatrogenic causes of the uterine rupture. Pathology. If it is incomplete, usually rupture of lower uterine scar or extension of a cervical. Complete rupture, usually disruption of the scar in the upper uterine segment. Rupture include disruption of the entire length of the scar, rupture of the membrane, varying degree of bleeding. The fetus and placenta. In incomplete rupture, the fetus and placenta may remain inside the uterine cavity or part of the fetus occupy in between layers of broad ligament. In complete rupture, fetus with or without placenta usually escapes out of the uterus. Diagnosis during pregnancy, scar. If it is a scar rupture, patient will have a dull abdominal pain with slight vaginal bleeding. Tenderness on uterine palpation, sooner rupture become complete. Spontaneous rupture, often high Paris woman, acute pain in abdomen with fainting attack and collapse. Diagnosis established by presence of shock, acute tenderness on abdominal examination, palpation of superficial fetal parts. If complete, FHS is absent. During labor, scar rupture, classical or hysterectomy, same as in case of pregnancy. Lower uterine scar rupture, onset is insidious, so marked as a silent rupture. Spontaneous obstructive rupture, it have a premonitory phase, usually in multiparous, initially pain severe, then it become continuous. On examination, patient is dehydrated, exhausted, heart rate and temperature are elevated. Abdominal examination shows distended and tender lower uterine segment, Bandel's ring visible, evidence of fetal distress. Phases of rupture include sense of something giving away at the height of uterine contraction and constant pain changed to a dull pain. Prophylaxis. High-risk mothers should have mandatory hospital delivery. General anesthesia is not used in giving external cephalic version. Undue delay in labor in multipara. Careful selection of cases for vaginal delivery after LSES. No internal cephalic version in singleton pregnancy. Treatment, resuscitation following by laparotomy. There is no scope for the resuscitation. We have to wait. No, there is resuscitation followed by laparotomy, hysterectomy. If possible, we have to repair. Sometimes it may be done with repair with sterilization. Next, obstetric emergencies, inversion of uterus. It is an extremely rare but life-threatening condition in which the uterus is turned inside out, partially or completely. Varieties. First degree, there is a dimpling of the fundus which still remain above the level of internal os. Second degree, the fundus passes through the cervix but lies inside the vagina. Third degree or complete, endometrium with or without the attached placenta is visible outside the vulva. Etiology. Spontaneous inversion occurs in case 40% of cases. It is due to localized atonia of the placental site over the fundus associated with sharp rise of intra-abdominal pressure, as in coughing, sneezing, or bearing down effort. Iatrogenic. This is due to the mismanagement of the third stage of labor, like pulling the cord when the uterus is atonic, faulty techniques in manual removal of the placenta. Dangers in inversion of uterus include shock, extremely profound, mainly neurogenic origin due to tension of the nerves due to stretching of the infundibulopelvic ligament, pressure on the ovaries as they track with fundus through the cervical ring, peritoneal irritation, hemorrhage, pulmonary embolism. If it is left uncared, it may lead to infection, uterine slugging, and chronic. Symptoms: acute lower abdominal pain with bearing down sensation. The signs include varying degree of shock. Abdominal examination reveal cupping or dimpling of the fundal surface. Bimanual examination helps to diagnose and confirm the degree. Prevention. Do not employ any method to expel the placenta out when the uterus is relaxed. That means don't try to pull the cord when the placenta is relaxed. Pulling the cord stimulates with fundal pressure should be avoided. Manual removal should be done in case manual. It should be means how it should be advised, that way it should be done in the case of manual removal. Management. Before shock develops, urgent manual replacement even without anesthesia. Principles: the replace the part first which inverted last. To apply counter support by other hand placed on the abdomen. After replacement, the hand should be remain inside the uterus until uterus become contracted by parenteral oxytocin. If the placenta is to be removed manually, only after the uterus become contracted. Usual treatment of shock, including blood transfusion, should be arranged as when required. After the shock develops, the principal steps include treatment of the shock. Push the uterus inside the vagina if possible and pack the vagina with antiseptic roller gauze. Foot end of the bed to be elevated. Replacement of the uterus either manually or hydrostatic method. Next, obstetric emergencies. Amniotic fluid embolism occurs when amniotic fluid containing particles of debris like vernix, hair, skin cells, or meconium enters the maternal circulation and obstructs the pulmonary vessels, causing respiratory distress and circulatory collapse. This can occur because the fluid can enter the maternal circulation anytime there is an opening in the amniotic sac or maternal uterine vessels. Amniotic fluid is more damaging if it contains meconium and other particular submatter such as mucus, fat globules, lanigo, bacterial products, or debris from a dead fetus because emboli can form more readily. Maternal death occurs most often when thick meconium present in the amniotic fluid because this clogs the pulmonary veins more completely than debris. Predisposing factors: rapid or precipitate labor, violent uterine contractions, multiparity, overstimulation of the uterus, uterine trauma. Signs include respiratory distress like restlessness, dyspnea, cyanosis, pulmonary edema, respiratory arrest, circulatory collapse, include hypotension, tachycardia, shock, cardiac arrest, hemorrhage, coagulation failures, bleeding from the incisions, venipuncture sites, trauma, petechiae, ecchymosis, purpura, uterine atony. Intervention: oxygenate. Administer oxygen by face mask. For resuscitation bag delivering 100% of oxygen. Prepare for intubation and mechanical ventilation. Initiate or assist with cardiopulmonary resuscitation. Treat the pregnant woman 30 degrees side to displace the uterus. Maintain cardiac output. Replace the fluid losses. For that, position the woman on her side. Administer IV fluids, administer blood, packed cells and fresh frozen plasma. Insert indwelling catheter and measure hourly urine output. Correct the coagulation failures, monitor the fetal and maternal status, prepare for emergency birth once the woman's condition is stabilized. Provide emotional support to the woman, her partner and the family. The body will respond in two phases. The initial phase is one of the vasospasm, which causes hypoxia, hypotension and cardiovascular collapse. Second phase is the development of left ventricular failure with hemorrhage and coagulation disorders followed by pulmonary edema. Presence of thromboplastin high in amniotic fluid, it blocks pulmonary artery and triggers the complex coagulation mechanism leading to disseminated intravascular coagulation. Next, obstetric emergencies, fetal distress or non-reassuring fetal status. It is an ill-defined term used to express an intrauterine fetal jeopardy as a result of intrauterine hypoxia. It is characterized by tachycardia or bradycardia, reduced FHR variability, disrelations and absence of accelerations. It must be emphasized that hypoxia and acidosis is the ultimate result of many causes of intrauterine compromise. Pathophysiology: under normal conditions, when the oxygen supply is adequate, aerobic glycolysis occurs in the fetus and the glycogen is converted into pyruvic acid, which is ultimately oxidized via Krebs cycle. During hypoxia, when the oxygen saturation falls below 40%, anaerobic glycolysis occurs, resulting in accumulation of lactic acid and pyruvic acid, leading to metabolic acidosis. The hydrogen ions first stimulate and then depress SA0, leading to tachycardia and bradycardia respectively. It also causes parasympathetic stimulation, leading to hyperperistalsis and relaxation of anal sphincter with the passage of meconium. Decreased fetal oxygenation leads to hypoxia, lead to metabolic acidosis, will lead to fetal tissue damage and to fetal death. Etiology: if it is acute and chronic. Acute during pregnancy is less common, but placental suppression in placenta previa or abruptio placenta following external cephalic version due to cord entanglement during oxytocin induction. And during labor, it is common uterine hyperstimulation following oxytocin for augmentation of labor, uterine rupture or scar rupture. When cord prolapse, injurious administration of analgesics and anesthetic agent, maternal hypotension as in case of epidural analgesia, placental abruption. Next is chronic, that is factors responsible for intrauterine growth restriction. Management: non-surgical management include lateral position to avoid compression of vena cava and aorta by gravid uterus. This increases the cardiac output and uteroplacental perfusion. Oxygen administration, nearly 6 to 8 liters per minute to the mother with mask to improve the fetal saturation. Correction of dehydration by IV fluids to improve the intravascular volume and uterine perfusion. Stoppage of oxytocin to improve fetal oxygenation. Tocolytic agents given when the uterus is hypotonous and there is non-reassuring fetal heart rate. Thus done are CTG to detect fetal acceleration and surgical include lower segment cesarean section. Thank you for listening. If you have any doubt, please feel free to ask. Thank you.